So I'm going to talk about a national strategy that we were involved in evaluating. This is back in the 2000s. So John, the next slide, please. Great, thanks. So in 2001, the New Zealand government introduced a new primary healthcare strategy that had a vision of people being part of a local primary healthcare service that improves their health, keeps them well, easy to get to and coordinates their ongoing care. And services will focus on better health for a population and actively work to reduce health inequalities between different groups. Next slide, John. Great. This was quite a complex strategy that did a number of different things all at once, which then poses all sorts of challenges for evaluation. And also one of the key issues with this is that it introduced all these changes across the country all at the same time. So you're not able to have some pilot programs and look at the impacts of those. You're having to evaluate a program that's been introduced across the whole country kind of all at once. And I'll talk about that in a few minutes. But some of the things that the strategy was doing was, first of all, was reducing barriers, particularly financial barriers for people in terms of accessing primary healthcare services. So as many people will know, in New Zealand there is traditionally there's been quite a high fee for seeing a general practitioner, and that fee had risen over time and was seen to be providing significant financial barriers, particularly for Māori Pacific groups and people with more health needs, lower income people, for example. So part of the strategy was to reduce financial barriers. Another change that was made was to support the development of what were called primary health organisations. And what was happening here was these were a new meso-level organisation introduced into New Zealand, building on some previous activity, but making all practices, general practices, having to join them. And what would happen was that individuals would enrol with a general practice, and that general practice would choose to belong to a particular primary health organisation. And these primary health organisations would actually support the development of primary health care. So they would organise all the money, all the backroom things that need to be done, but also start to develop services as well. Another key thing that the strategy was looking to do was that recognising that for many years New Zealand primary health care had been largely delivered by general practitioners, often working on their own, maybe with a practice nurse, but they're in small practices on their own. And so this was just part of the strategy was actually trying to encourage multidisciplinary approaches to services and more decision making by teams as well. And there's also a desire to support the development of services by Māori and also by Pacific providers as well, who might better meet the needs of those communities. Next slide, John. Okay, so to support these particular changes, these are some of the things that actually then happened. So the first thing was that there was a significant amount of new money going into primary health care. About $2.2 billion was planned for about a 7 or 8 year period. That money was to go through primary health organisations down to general practices to enable those practices to reduce the fees that people pay when they use services. And the money was rolled out firstly to what were called access practices, which were serving higher needs communities, and then rolled out over time, sort of year on year, to different age groups in the other practices. And other funding was then introduced to extend services and also develop new services as well. We had the establishment of these not-for-profit primary health organisations that would sit over the top of general practices and help them develop services. And we also shifted from what was a targeted funding approach to a more universal funding. So prior to this, only some people in the population had access to government subsidies to help them access primary healthcare services. Now we were moving to a universal funding arrangement. And the funding formula also changed. So we moved from having fee-for-service for general practitioner services, so a general practitioner being paid every time someone went to see them, to capitation paid to primary health organisations and then paid on down to individual general practices. This promotes better equity by allocating resources based on need rather than just those who actually turn up at a general practice, and the funding formula was weighted by age, gender and ethnicity. So as you can see, a whole lot of changes there all going on at once. Next slide, John. Great. So where does health services research come into this? Well, one of the first things was that there was some international evidence on which this primary healthcare strategy was actually based. And I guess in New Zealand, there'd been quite a bit of work prior to the introduction of the strategy to sort of look at what are the different models of primary healthcare that we might have, what will happen if we do some of the changes that we've just kind of talked about. So there was some evidence that a strong primary healthcare system would support a lower cost, more equitable health system. The good evidence that if we had cheaper primary healthcare services, that will lead to an increase in use of services, particularly for lower income people. Some work that had been particularly done in the United Kingdom on the role that primary health organisations as meso-level organisations might play in some of the issues that they might actually face in terms of getting themselves established and building relationships with the general practices that they work with. And there was also some New Zealand evidence and some international evidence, but it's a bit unclear about whether the change to capitation on its own would actually lead to a broadening of the general practice workforce. In other words, will we get an increased role for nurses? Would other primary healthcare staff come into practices such as social workers, pharmacists and so on? And it was some New Zealand examples where that hadn't necessarily happened as a result of a change to capitation. Next slide, John. So one key thing with this is how are you actually going to evaluate it? As I said, you can't do a pilot and everything's kind of being rolled out across the whole country all at the same time. So our focus was really on a formative evaluation, exploring implementation, and then really a before and after design, which was actually then looking at key achievements. And of course, you couldn't be sure that it was only the things that were actually changing as a result of the strategy that would be responsible for what was changing, but there was no other design that we could actually use for this. This particular project was funded by a mix of government organisations and our Independent Health Research Council, and so we were working directly with policymakers throughout the evaluation. And it was a large national team of researchers, so people in Wellington, Auckland, the South Island, working together from a range of different disciplines as well. We used a mix of methods, as is common in health services research, so reviewing key documents, strategy documents, plans, minutes of meetings, those kinds of things. A large number of key informed interviews across the country, again with policymakers, those working in primary health organisations, those working in practices. We did a survey of primary health organisations. At this point in time, there was more than 80 of them, so they were all rung up, and we did a kind of over the phone survey with them. We got a lot of information about the PHOs, and we also did a survey of practices as well. And then we had quantitative analyses, look at before and after of administrative data, which I'll talk about in a few minutes. We had really good participation overall in this evaluation. One of the key things was that the strategy was really well supported, and so people were keen to support the evaluation as well, so that was great. But we did face some key difficulties in doing this. First of all, we were unable to track the new expenditure over time. So although the government said it was going to spend $2.2 billion, we don't know whether they did. One of the key things is that there's no national primary healthcare data set in New Zealand, so there's nowhere to go to track fees information, what it is that people are actually paying when they see a GP, nor utilisation data either. So we had to work with a group that worked directly with a number of different practices, and they downloaded the data directly from the practices and then analysed it using before and after methods. We had to work very hard to get a good response rate from the general practice survey. This is an ongoing issue in primary healthcare research. You have to put a lot of time in getting people to actually complete the survey. And one of the key issues with this was that the evaluation actually didn't fund research with consumers. So we weren't able to kind of talk with consumers and say how were the changes in service delivery affecting them. Next slide, John. So just some key findings. This goes back now around 8 years or so, but some of the key things that we found, which are then important in a policy context. First of all, there was very strong support for the strategy and of course strong support for having new funding going into primary healthcare. This was actually one of the first times since the 1930s, 1940s that primary healthcare had had so much attention paid to it. There was almost full enrolment, so almost all New Zealanders over a number of years ended up enrolled with a particular primary health organisation. There were large numbers of primary health organisations had developed. The government hadn't said there can only be so many, it just allowed as many of them as wanted to develop, so there were more than 80. And of course there was significant variance in their size and their makeup and their roles. And one of the key things that we were a little bit concerned about was that some of them only seemed to be post boxes for the funding, and that is that the money was just going straight through them down to general practices, and it was unclear what role they were actually then really playing in terms of developing primary healthcare services. And some concern about overlap between New Zealand's district health boards and these primary health organisations in terms of their roles. When it came to looking at consultation rates for primary healthcare services, they did initially increase as the new funding was rolled out and as the fees that people paid actually fell. This was a really complicated analysis to do because I talked about before there was that complex rollout of funding and we had to break down the analyses into all those different groups in the population in terms of when they got new money that would allow the fees that they pay to fall. One key thing that we found was that the fees did not fall by as much as the new government money. So new money was going into primary healthcare and the fees were falling really only by about half as much as you might have expected. So the government might have expected to fall in fees of about $25 per visit, but they were only going down by about $12.50 on average. And that's because some of the money was then being kept in primary healthcare practices. The number and proportion of nursing services did increase significantly as well, so nurses began to play a much stronger role in primary healthcare service delivery. And then in terms of the other things that might be expected from these changes, there was actually little sign of them. So there was very little change in models of care. It was still very much focused on a 15-minute GP consultation, and the focus on integration wasn't really happening either, so integration with other primary healthcare services and hospital services and so on. Next slide, John. So just some reflections. I was thinking about this. We're about to start, we'll get involved in some new work potentially in this area, and I was just reflecting on the evaluation and also what we found. Following all the work that we did, further changes were made in the sector. For example, primary health organisations were amalgamated and there's now around 30 of them, and there was an increasing emphasis on integration. But there's actually been very little recent research, and we know very little now at the moment about the models of care that are actually out there, about integration, about roles and relationships, and still there's almost no research still with consumers. So we really do not know how all of these changes over a 17-year period are actually affecting consumers and the services that they use.